So first of all, I'd like to thank Victoria and also for the Stanford Blood Center for kindly inviting me here to speak today. So as Victoria mentioned, I'm going to be talking about management of common sleep problems. And these are my disclosures that are relevant to this particular presentation. So I'm going to basically cover three main topics. The first is the need for sleep. Then I'm going to cover two of the most common sleep disorders of the more than 90 different sleep disorders out there. So first of all, why is sleep important, or why is sleepiness important? As you can see, it's estimated that at least 36% of the population suffers from sleep loss. And this includes 1/3 of young adults secondary to chronic partial sleep deprivation, about 7% of adults secondary to sleep disorders, and about 2% of adults secondary to shift work. Now, interestingly, 1/3 of adults sleep less than 6.5 hours during the work week, and approximately 1/3 of normal adults fall asleep in less than or equal to 5 minutes. The way we know this is that there's actually a test called the multiple sleep latency test, which is conducted in sleep labs throughout the world. And what happens is that we have a person sleep overnight at our lab, and the next day they have 5 scheduled naps. Each nap lasts 20 minutes, and each nap is separated by 2 hours. So you have naps at 9 o'clock, 11, 1, 3, 5 p.m. And then we see how long it takes them to fall asleep. And what happens during these 20-minute naps is we average across those 5 naps the average time it takes them to fall asleep. So if they fall asleep in less than or equal to 5 minutes, that's considered excessively sleepy. So it's considered pathologically sleepy. And the cutoff for normal versus daytime sleepiness is 8 minutes. So 8 minutes is a cutoff, but if you're less than or equal to 5 minutes, it's considered pathologically sleepy. Now, also interesting is when total sleep times in normal young adults are reduced just by 1 to 1.5 hours for one night, you get decreases of up to 1/3 in objective alertness the next day. So just one night of partial sleep restriction produces decreases in up to 1/3 in objective alertness the next day. So it does have profound ramifications for lack of sleep. So some of you might know that sleep is divided into 2 main states. You have non-REM sleep, and you have REM sleep. So REM sleep stands for rapid eye movement sleep. And it's actually a time of cardiorespiratory instability. What that means is that's when the heart rate becomes irregular, and also the breathing becomes shallow and irregular. That's also the time, if you have obstructive sleep apnea, when the apnea is worse. Because, as I mentioned, even in normal people, the breathing tends to get shallow and irregular. Now, as many of you probably know, REM sleep is a time when most of the dreams occur. So about 90% or more of the dreams occur during REM sleep. And then for non-REM sleep, you see it's divided into 3 stages. This is kind of the newer terminology. Before it used to be called 1, 2, 3, and 4. So now 3 and 4 are sort of lumped into N3 sleep. But as you go the higher numbers, it's more the depth of sleep. So N3 sleep is the higher depth in humans. So that's when it's most difficult to wake a person up from sleep. And this just shows the progression of sleep over the lifespan. You can see that when you're a neonate, that you have a lot of sleep. You have close to about 16 hours or more of sleep. And then you also notice that 50% of that sleep is REM sleep. And that's why REM sleep is thought to be due to things like brain maturation and growth and development. And as you can see, as you get older, the amounts of non-REM and REM sleep decrease over time. This is shown a little different way, and this also has, as I mentioned, kind of the older terminology of stages 1, 2, 3, and 4 of non-REM sleep and REM sleep. And you can see when you're a child that you have pretty good sleep. You might wake up once during the night, but for the most part, you have pretty good sleep. And as you can see here, in children and adults, most of the deep sleep, the N3 or stage 3 and 4 of deep sleep, is in the first third or first half of the night. And you can see a very nice progression of REM sleep. So REM sleep cycles in about anywhere from about 60 to 90 minutes during the night. And so you'll have about 3 to 6 REM periods during the night. And the REM sleep tends to get more intense and longer as the night wears on. So childhood is really a good example of really good sleep. As you get older, already by young adults, you start to become a little less efficient in your sleep, meaning that the time that you're in bed and actually sleeping tends to start dropping off. So optimally, when you're in bed, you should sleep about 90 to 100% of the time that you're in bed. But as you get older, and in cases such as chronic insomnia, your sleep will become much less efficient, meaning that you might sleep about 40 to 50% of the time that you're in bed. Now, as you get even older, what happens is that your sleep becomes less efficient. You start to have more awakenings during sleep. You start having difficulty falling asleep, and you notice that the amount of non-REM and the REM sleep starts decreasing in time. And then also, because of these frequent interruptions in your sleep, you would tend to get more sleepy during the daytime. And what's not shown here is that another thing that's observed is that as you get older, your circadian rhythm starts shifting, meaning that you'll want to sleep earlier and get up earlier. And a lot of that due is to the fact that the circadian pacemaker, so the pacemaker or group of cells that governs the sleep-wake cycle, is found in this nucleus of the brain called the suprachiasmatic nucleus. And like any other cell in the body, as one ages, you tend to have some cell loss there. And because of that, it's thought to shift the circadian clock. Now, what's interesting was a few years back, a bunch of us gathered into a room such as this. It wasn't quite as crowded, but nevertheless, it was a room like this. And what happened was we decided to review the literature regarding what is a total sleep requirement. And we actually published our results just a few years ago in 2015. So in the course of it, we reviewed about several thousand articles concentrated on sleep duration. And what we did was we came up with, based on that evidence, we decided to come up with a consensus statement. So our consensus statement was that adults should sleep 7 or more hours per night on a regular basis to promote optimal health. And there's always some caveats regarding who might sleep less, and you can read those here. And sleeping more than 9 hours on a regular basis may be appropriate for young adults, individuals recovering from sleep debt, and individuals with illness. For others, it's uncertain where sleeping more than 9 hours per night is associated with health risk. And as usual, we did have a disclaimer that people that are concerned they are sleeping too little or too much should see their primary care physician. What was interesting was we didn't come up with an upper bound, but another group, the National Sleep Foundation, actually came up with an upper bound, which was 10 hours. So they concluded that sleeping less than 7 hours or greater than 10 hours was not optimal, that the actual optimum period was between 7 and 10 hours. Now, what's interesting is there's a lot of things that sort of determine when you become sleepy. As you notice over here by this graph, you can see this is clock time, and this is military time, so 1400 would be 2 o'clock or 2 p.m. And as you can see by this, that the subjective alertness, where 100 is very alert and 0 is not very alert, definitely dips throughout the day. And a lot of that is timed in with core body temperature. So core body temperature, when you start dropping your core body temperature, that's when you start also having some daytime drowsiness or nighttime drowsiness. In addition, it's tied in with plasma melatonin. So as your melatonin peak rises, that's when you tend to be more sleepy as well. Now, one thing that you can use very handily to determine whether or not you might have subjective daytime sleepiness is by taking this scale called the Epworth Sleepiness Scale. And the reason why it's called that is that the developer of this scale was a person named Mary Johns, who's one of our sleep colleagues that lives in Epworth, Australia. So that's why it gets its name, Epworth Sleepiness Scale. But you can download it off the internet. And it's a good guide to sort of determine whether or not you might have daytime sleepiness. So the way you complete this scale is you look at these situations during the daytime, and then you put 0 for would never doze, 1 for a slight chance of dozing, 2 for a moderate chance of dozing, or 3 a high chance of dozing. So you code each one of these as 0, 1, 2, or 3. Then you add it up. And obviously the highest you could get is 24, the lowest is 0. But if you're over 10, then you might want to sort of think if you are getting enough sleep. Because there's two things that really can determine the amount of daytime sleepiness you have, and that's the quantity of your sleep and the quality of sleep. So the low-hanging fruit is to determine, are you sleeping enough? If you're sleeping like, less than 7 hours, then you might want to increase the number of hours of your sleep. But if you've already done that and you're still very sleepy, then the other thing would be your quantity of sleep. And that can be not that obvious. And that's why you would want to discuss it with your primary care physician or your sleep specialist, just because there might be conditions, sleep disorders or medical disorders that might be impacting your sleep that you're not aware of, and that might in turn lead to the daytime sleepiness. Now I'm going to shift and talk to a disorder of excessive sleep, which is obstructive sleep apnea. And it has even been noted in the time of Dickens when he wrote in his Pickwick Papers and on the box sat a fat and red-faced boy in the state of somnolency. He was actually called Fat Boy Joe in the book. And the reason why I pointed this out is that that's one of the misconceptions of obstructive sleep apnea, that you have to be overweight to have this condition. About 30 to 67% of the people that have sleep apnea are obese, defined by a body mass index of 25 kilograms per meter squared or higher, but the rest are not. And certainly here in California, we see a lot of fit people that end up having obstructive sleep apnea. And I'll go into some of the risk factors, the physiological risk factors and anatomic risk factors that might be responsible for that, for those statistics. So what are the basic symptoms of obstructive sleep apnea? Well, you have loud disruptive snoring. You also have witnessed breathing pauses during sleep, and you have excessive daytime sleepiness. Now, I sort of lump in these adjectives altogether like fatigue, tiredness, and exhaustion, but it is truly excessive daytime sleepiness. And sleep specialists are very picky about the terminology. They tend to consider sleepiness and drowsiness different, but along the continuum of people that are tired and fatigued. So the true litmus test is that Epworth scale that I was showing you earlier. So these are people that can really nod off and sort of fall asleep. People that are more fatigued and tired, such as maybe some people, the majority of people with insomnia that might have more fatigue and tiredness, those are people that if you put them in a darkened room during the daytime, the same mechanisms that prevent them from falling asleep during the night also prevent them from falling asleep during the daytime. So they'll have difficulty falling asleep even in optimal conditions for sleep. But they will feel terrible. They'll feel very tired, run down, fatigued, but they won't be able to take naps during the day. And certainly during the night, they're not able to fall asleep and have a good sleep during the night. But actually, before I show this, one distinction of these groups, another critical distinction, is that they will feel very sleepy during the daytime, but they won't feel this fatigue or tiredness. And then the amount of sleep that people that feel fatigue and tiredness get is enough to prevent them from feeling very sleepy during the daytime. But the distinction is that it's not enough to make them feel run down. So they'll feel run down and tired, but they just won't be able to be sleepy during the daytime. Okay, so this is a child that has obstructive sleep apnea. You can notice that there's a lot of respiratory effort that's occurring. The child is really trying to bring in a breath. And if you listen very carefully, and the audio isn't the best to hear, but you can hear the gasping that's occurring with this pauses in breathing. And the timing of the breathing is very irregular. And there's also these capture breaths as the child tries to bring in a breath after the pause in the apnea. And what happens is there's a lot of these rib flaring, so the ribs are definitely trying to bring in a breath. And it's no wonder that these children during the daytime, they'll be very irritable, moody, and have difficulty focusing and concentrating. So it very much mimics children that have attention hyperactivity disorders. So they can have ADHD-like symptoms. In addition, it's not unusual for them to wake up with a lot of sweating and also complain of morning headaches because of the oxygen deprivation associated with the obstructive sleep apnea. So the prevalence of sleep apnea in adults is about 24% of adult men, 9% of adult women between the ages of 30 and 60. It's about 40% of all patients in a primary care setting, and in childhood, it's about 3%. These are some of the predisposing factors. Middle age is the common age of getting or manifesting the symptoms of obstructive sleep apnea and being diagnosed with this condition. And part of the reason is the upper airway tends to get more collapsible with age, so it tends to be it tends to lose its tone, the muscles that are responsible for keeping the airway open. So this tends to have its effect. Obesity, I mentioned, it does, the prevalence is about 30 to 67% of the people that do have obstructive sleep apnea are overweight. And then you can see this interesting male gender discrepancy. So what we believe is responsible for this is that women have a protective effect of the airway due to the hormones like estrogen and progesterone. But after menopause, interestingly, this ratio gets very similar for men and women. Now, if the woman elects to go on hormone replacement therapy, then this ratio drops to this before menopause. Also, hypothyroidism, some medications such as the benzodiazepines, which are things like, for instance, Valium, Ativan, they can relax you, but also they tend to relax the upper airway as well. Same thing with alcohol. Alcohol will make it very easy for the person to fall asleep. It does fragment the non-REM and REM sleep and cuts down on the total amount of sleep. But in addition, because it relaxes the upper airway, it makes it more susceptible to having obstructive sleep apneas. And then there's also anatomic abnormalities, which I'll cover. This is called the Stop Bang questionnaire. It was developed by one of my colleagues named Francis Chung in Canada. And basically, it shows what your risk might be for having obstructive sleep apnea. And also, this is available on the internet. So we know that sleep disordered breathing, such as sleep apnea, increases cardiovascular mortality and overall mortality, and that it also increases stroke risk. It also increases the risk of having a motor vehicle accident. And if you have these symptoms like the snoring, tiredness, sleepiness, observed apneas, and high blood pressure, if you have two or more of that, these conditions, you're at higher risk for having obstructive sleep apnea. It's more likely to have obstructive sleep apnea. So having two or more of these symptoms will make it more likely that you might have obstructive sleep apnea. And we're starting to use this questionnaire also in other clinical services as a way of sort of screening people that might have obstructive sleep apnea. Now, this term craniofacial dysmorphism is just a fancy way of saying, do you have some anatomic features that might predispose you to having obstructive sleep apnea? So you can see here a normal structures would be people that have a normal bony enclosure, and that means the maxilla and mandible. So basically, the upper and lower jaw. And I'll go into this in more detail. And then also, if you have a lot of soft tissue surrounding your upper airway, this might predispose you to having a narrow airway. But if you're normal, you'll have less soft tissue, you'll have a normal bony enclosure, and you'll have consequently a normal airway size. But if you're overweight, and this translates, and the reason why it translates is that if you tend to have particularly truncal obesity, so in men, if you tend to have a lot of upper body obesity, that can translate to sort of upper airway fatty tissue deposits. So you'll have fatty tissue deposits around the upper airway, and that can make the airway narrow, such as this. So even the bony enclosure, so even though you might have a normal size upper and lower jaws, if the fatty tissue around your airway is quite a bit, it will condense the upper airway size. Now, what's worse is if you have a smaller maxilla and mandible, so if your upper and lower jaws are small, that can cause your bony enclosure to be smaller, and in turn, that will also cause problems with your upper airway. And if you have both obesity plus a smaller upper and lower jaw, then it's even worse. And one of the things we always look for too is, as part of the exam, we look into the nose. And the nose is important because we concentrate our exam on the turbinates. The turbinates are these soft tissue that are in the nose, and you have three sets of these turbinates on both sides. And basically, what we look is we look at the inferior turbinate, which is shown here, and what we see is how large it is. And that can be variable. It can be dependent on things like, for instance, if you have a lot of allergies, then the turbinates will be enlarged. But some people, because of numerous infections, these turbinates are chronically enlarged. The consequence is that if your nose is occluded, and I have to preface this by saying your nose has to be almost completely occluded. So if you close your mouth and during the daytime you breathe and you can't breathe through your nose, that's that's what I mean by pretty significant. And in those cases, about 5% of the people that have obstructive sleep apnea, it's due to that degree of nasal congestion. We do know that for people that even have a slight degree or a moderate degree of nasal congestion, it can also translate to obstructive sleep apnea. So if these turbinates are somewhat enlarged, and say you have a really bad deviated nasal septum, and your flow through the nose is restricted, that can cause abnormal distribution of the airflow in your upper airway. And in turn, that can make your obstructive sleep apnea worse. So that's why even for children, if they start to have bad allergies, we try to address that, just because it can lead to a pattern of abnormal anatomy that I'll show a little bit later. So this is some of the consequences. So if you do tend to have some significant nasal obstruction, it can actually lead to a lower jaw. So meaning lower jaw abnormalities, you can have a recessed jaw. And this can also occur independent of having nasal issues. But if you do have this nasal jaw, what happens is that there's a higher likelihood of having obstructive sleep apnea. And the other thing is that that's depicted here and these are called cephalometric x-rays. And normally, if you go to your nose and throat for nasal congestion or for obstructive sleep apnea, they might take these head x-rays. They might also do a fiber optic examination of your nasal and oral airway. But the idea is to see your jaw structure and to see if that might be a confounding factor for your obstructive sleep apnea. Now, in addition to a lower jaw that's pushed back, a person might also have a mid-face deficiency, meaning that on the upper jaw, the mid-face is depressed backwards. And that can also result in abnormalities leading to obstructive sleep apnea. And the mid-face deficiency is mainly noticeable in people that have maybe not a large nose, that the whole mid-face tends to be pushed back. Now, one of the more obvious consequences, one might be, well, it's obvious mainly to sleep specialists, but for people that do have a lot of nasal congestion that's untreated over time, is it can lead to this open lip posture, which is shown here. And one person that I always kind of notice on the TV that I think might have had a lot of nasal congestion leading to possibly obstructive sleep apnea is John Elway, because he has sort of like this open lip posture. And the idea is that this is normal resting posture for their mouth. I'm sorry, John Elway. He used to be the quarterback for the Broncos. And just notice that this open lip posture is at rest. They can't completely close their lips. And part of that is due to what we think is significant nasal obstruction during growth and development, so during childhood. And because of this significant nasal obstruction, what happens is it causes some of those changes that I showed in the previous slide, where you tend to have a pushback lower jaw. In addition, the jaw lengths, or jaw lengths from, in this dimension, the anterior posterior dimension, tend to be increased, and you might have some mid-face deficiency. So this can lead to this open lip posture. And what happens is you become what's known as an obligate mouth breather. So you tend to breathe primarily through your mouth, and that in turn creates this cascade of these anatomic abnormalities that I mentioned. Now, another way is also with the obesity that I mentioned. And for men, it tends to, if you have greater than a 17-inch neck size, there's a higher risk of having obstructive sleep apnea. And the reason is shown right here, is that these are people, this is a person without obstructive sleep apnea. And I mentioned that there's these fat pads. They're actually called the lateral parapharyngeal fat pads that surround the upper airway. So as you put on weight, you might get the weight translated to the neck and these lateral parapharyngeal fat pads. And that, in turn, would cause more collapse of the airway. And I mentioned that in men, it's more the truncal obesity. In women, it tends to be more, the hips and the waist. So that might be another one of the reasons why it's not the prevalence of obstructive sleep apnea in women tends to be a little lower. Because even if you take apart the menopause, what happens is that we notice that in women, the obstructive apneas tend to be shorter in duration, and the amount of oxygen desaturations that occur, or oxygen drops that occur with the apnea tend to be less compared to men. So there's a lot of gender differences. This shows it another ways. RP stands for retropalatal. That means behind the soft palate or behind the uvula and the soft palate. Retroglossal means behind the tongue. And you can see that in this three-dimensional reconstruction of CT scans, that a person that has obstructive sleep apnea tends to have a narrow upper airway compared to a person that doesn't have it. And it extends from the palate all the way down to the base of the tongue. So one thing that we always do, when a person comes to see us, is we always tell them to open up their mouth and stick out their tongue. And I know you have this done when you see your primary care physician, but for us, we look very specifically at certain things. So one of the things we first look at is the uvula and the free edge of the soft palate. If this area is very red and swollen, and there's a lot of redundant soft tissue back here, then 9 times out of 10, it's either a person that snores really heavily, because this is the area that tends to vibrate most with heavy snoring, or they might just be getting over a virus or a cold. So that's one thing that we look at. The other thing that we look at, especially in children, is we look at their tonsils. And if in children, if the tonsils are very swollen, then that is definitely a major risk factor for obstructive sleep apnea. Because if the child has swollen tonsils and adenoids and is diagnosed with obstructive sleep apnea, an adenotonsillectomy, so removal of the adenoids and tonsils, is 90% curative. But in adults, it's more complicated. Just removing the tonsils and adenoids won't be curative. But in children, it is. So that's why we look at the tonsillar size in children. The other thing that we look at is we look at the free edge of the tongue. And we look specifically for what's called scalloping. So if the tongue has scallops on the edge, we become very suspicious that during development, either the lower jaw that I mentioned is smaller than normal, or the tongue is larger than normal. In either case, during development, the tongue will always be hitting against the back of the teeth, and that will leave scalloping on the edge of the tongue. So there'll be these dental impressions of the lower jaw that are on the tongue. And as I said, that's definitely a risk factor because that implies that the lower jaw or the tongue might be smaller. Now, also, we tend to look at this oral aperture. So if we tell the person to open the mouth and say, and we don't see that aperture, that means that during development, this soft palate, the edge of the soft palate is diving behind the edge of the tongue, the back of the tongue. And that invariably means that the person probably has maybe a moderate to severe case of obstructive sleep apnea. Because if we can't see this area, this oral aperture, even when the person sticks out their tongue and says, chances are, the aperture at the base of the tongue is also equally narrow. And this is shown here by a person that does have obstructive sleep apnea. The uvula is so elongated, it's actually doubled over. And this base of the tongue, also called the oropharyngeal hypopharyngeal area, which extends from the tip of the uvula down to the vocal cords, is also narrowed. So you can see why this person would have problems breathing during sleep. And as I mentioned, during REM sleep, it's worse. But also when the person lies on their back in the supine position, that's when it's also worse because this genioglossus, the main tongue muscle, would tend to collapse back in the airway just by the effects of gravity. So this complicated slide just shows some of our understanding of what happens during sleep for a person that does have obstructive sleep apnea. So if a person has a deficient upper airway anatomy, as I was describing earlier, during wake, this deficient upper airway anatomy, so even though they might have really swollen fat pads or a small lower jaw, a big tongue, when they're awake, the muscle activity of the tongue muscle will keep the airway open. But during sleep onset, what happens is you have a decrease in upper airway muscle tone, you have a decrease in lung volume, you have a decrease in the brain's central respiratory drive. And in turn, that will lead to the upper airway collapsing. Then what happens is your oxygen starts falling, your CO2 starts rising. Then your central respiratory and upper airway muscle drive are activated, and you get an arousal or awakening from sleep. And these awakenings are very brief. They're just enough to get the upper airway muscle tone up, the lung volume up, and a questionable ventilator response to the arousal. Now, it's not enough to wake up your brain. Let me rephrase that. It's enough to cause a transient awakening of your brain, but it's not enough to make you conscious of that awakening, unless it's a really big awakening. But just to give you some frame of reference, a person with very severe obstructive sleep apnea, they might have 100 or more per hour of sleep of these apneas. And correspondingly, they might have a significant number of those apneas associated with a 3% shift in their EEG rhythm, which indicates wakefulness. So they might have 100 or more of these tiny awakenings during the night, but they might only be aware of 1 or 2 of them when they wake up. Okay, so then what happens is then the upper airway opens up, and then because of that, they start having this hypoxic or decreased oxygen and hypercapnic increased CO2 levels, which lead to hyperventilation. So they start breathing really rapidly. And then that in turn will start blowing off their CO2, but it will also increase their oxygen. And then what will happen then is that will lead to decreased central respiratory and upper airway drive. So it's a cycle that will repeat many, many times during the night for a person that does have obstructive sleep apnea. So this shows some of the consequences of obstructive sleep apnea. You'll have, it's broken down into major categories such as problems with daytime functioning. I mentioned the daytime sleepiness. You can also have these other problems. You can also have cardiovascular and cerebrovascular disease. So you can have a lot of these consequences. You can also have diabetes and other endocrine abnormalities associated with obstructive sleep apnea. Now, what's interesting is that with sleep disordered breathing or obstructive sleep apnea, we notice some things, and this was part of a study that my team looked at. It was called the Apnea Positive Pressure Long-Term Efficacy Cardiovascular Outcomes Research Study, or APOCORS for short. And basically, we were looking at some of the effects of sleep disordered breathing on the physiology. And what we found out was that, as has been published, a lot of things such as the repetitive oxygen drops, reactive oxygen species within the body. You can have activation of the sympathetic nervous system with sleep apnea. I mentioned you can also have the increased CO2 levels. You can have the sleep fragmentation, and you can have inflammation. This has an effect on the endothelial cells, which line the major blood vessels in the body. And what happens when you have endothelial dysfunction, it leads to vasoconstriction and decreased levels of the mediators that enhance vasodilation. You can also have increased coagulation of the blood, and you can also have an influence on these cytokine or growth factors. All of these have an effect on the endothelial cells. So the endothelial cells are thought to be the final common pathway that leads to perhaps the atherogenesis. So what happens is that when you have problems with the endothelial cells that line the blood vessel, it causes these cells to become disordered. And there's more of a chance for these disordered cells to develop blood clots. And because of that, that could potentially lead to some of these cardiovascular complications. But this is an area that's under intense study right now. Now, if you look at survival curves, this is one of the more compelling evidence that indicates that obstructive sleep apnea does have an impact on not only all-cause mortality, but also the cardiovascular system. So this shows over time, years, 0 to 10 years. It also shows survival probability. And you can see this is a person that has what's considered normal in terms of obstructive sleep apnea, so less than 5 abnormal breathing events per hour of sleep. But what you can see is the greater the severity of the obstructive sleep apnea, the less predicted survival over time. Now, so what happens in our lab? So if you come in our lab and you have the loud snoring, you have the witness breathing pause and the daytime sleepiness, and we take a look in your airway and it looks pretty narrow, at least from the oral cavity, then our next step would be to do a sleep test. And for both the in-lab as well as the home sleep test, what we look for is we look for the obstructive apneas. And the obstructive apnea is actually a pause in the breathing, in the airflow through the nose and mouth, lasting at least 10 seconds, despite persistence of rib cage, meaning thoracic, which is chest wall, and abdominal cell wall motion. So despite the person trying to bring in a breath, there's still this pause in the airflow. And since the oxygen isn't reaching the lungs, you're going to have a corresponding drop in the oxygen saturation in the blood. And this is a 2-minute clip of a person in our lab that shows what happens when you have this drop this shows the brainwave activity, this shows the chin muscle activity, this shows the right and left eye movement, this shows the leg movements of the left and right anterior tibialis, which are muscles in the leg. This shows the EKG or heart rate, snoring microphone, oxygen saturation in the blood, airflow through the nose and the mouth, chest and abdominal wall movement. And this is another thing that we look at sometimes, which is a PAS, which stands for an esophageal catheter. So we place a catheter into the nose that goes into the esophagus that gets transmitted pressure in the airway. So it's a way of looking at work of breathing. So what you see right here is the person has a pause in their airflow. The person is trying to dramatically bring in a breath, and that's reflected both by the abdominal and a chest wall movement, but also by this work of breathing. Eventually reach a point where they wake up. So they have a tiny awakening, which restarts their breathing. But you notice what a drop in oxygen the person can have. Normal is 90% or higher, but it's not unusual for us to see drops down to 30%, which is almost what we think is incompatible with life, but we have seen that. So what can we do to treat it? Well, the most common treatment is positive airway pressure, and as I'll show a little later, it's divided into CPAP, which stands for continuous positive airway pressure, also bilevel positive airway pressure, which is more pressure as you breathe in, less pressure you breathe out. There's also surgery for the upper airway, which I won't go into any great detail here, but there are these well-developed techniques, predominantly here at Stanford, which can be effective. There's also oral appliance, which I'll also show a little bit later, as well as hypoglossal stimulation. There's also nasal valves and stents to sort of prop open the airway. There's negative pressure devices, weight loss, behavior modification, which is just a fancy way of saying try to keep the person on their sides rather than on their back during sleep. And there are some respiratory stimulants which haven't really been shown to be that effective. So these are the devices I mentioned, and you can see the most two common one are the CPAP and bilevel pressure. There's also auto-titrating positive airway pressure devices for both CPAP and bilevel pressure, as well as ventilatory devices during sleep. Now, what's interesting is for another study that our team looked at is what is the adherence to CPAP? And you can see what happens is that although in principle we'd like people to use the devices 7 or more hours during sleep, the most dense usage actually occurs between 300 and 500 minutes. And there's a lot of usage below that. So because of the discomfort that can be associated with these devices, the adherence really isn't that great. And on top of that, there are some side effects. But CPAP and bilevel pressure are still the most common and effective methods to treat obstructive sleep apnea because it does work and it does make a profound difference in a person's life. And this is just one of them. This just shows subtherapeutic is just sham CPAP. So it looks like, sounds like, and acts like a CPAP device, but it delivers pressure in the range of about 0.3 centimeters of water pressure, whereas most people need pressure in the ranges of 5 to 22 centimeters of water pressure. So a sham device delivers subtherapeutic CPAP pressures. So this is the baseline condition. These are the two groups, those that received active CPAP, which is shown in the dark circles, and the sham CPAP, which is shown in the open circles. And this is during the 24-hour period. Now, over here, you can see what happens to blood pressure for a person that's on the active and sham CPAP devices. So what's interesting is that the blood pressure decreases compared to the sham, people on the sham devices. So the blood pressure significantly decreases. But also during the daytime, this effect also occurs during the daytime. So even though these devices are used during the nighttime, it does have a positive effect on the blood pressure during the daytime as well. This shows oral appliances, and this just shows one of the oral appliances. And basically what happens is these oral appliances clip on the upper and lower teeth, and there's these tabs that prevent the lower jaw from being pushed backwards. So what happens is that the person can open up, oh God, I'm running over time. But the person can open their mouth and move the jaw from side to side. These tabs just prevent the jaws from being pushed backwards. And that's what's shown here. So in the normal position, the airway is narrowed, but when the upper jaw is moved, the lower jaw is moved forward, you actually get more opening of the upper airway, and that's the principle behind the oral appliances. And this shows the advantages and disadvantages of oral appliances compared to positive airway pressure. So you notice that the oral appliances are much more superior in terms of convenience, patient and partner acceptance, tolerance, and adherence, but it isn't as good as CPAP in terms of improvements of actual objective obstructive sleep apnea. This shows just a snapshot of upper airway surgery. This is one of the major surgeries, which is biomaxillary advancement, which is making cuts in the upper and lower jaws and moving them forward. But you can see it can have a profound increase in the posterior airway space before and after upper airway surgery. And it's estimated that you can have, for biomaxillary advancement, up to 9% curative with this type of surgery. This is one of the newer devices that we have in our lab, which is hypoglossal stimulation, which is implantation of a stimulating electrode into the hypoglossus or genioglossus muscle. And then there's a neurostimulator that detects the breathing cycle and gives a small electric shock, which is not enough to wake the person up, but enough to move the lower jaw, to move the tongue muscle forward, and that in turn will open up the airway. And for selected patients, it's shown to be very effective in controlling their obstructive sleep apnea. We also have experimented with nasal stents, which are these small flexible stents that go into the nose and can prop open the nasal airway. And you can see where it fits into the upper airway. And it can also be effective for mainly people that have moderate to severe apnea in selected cases. Okay, well, in the remaining time, which is nil, I'll try to go into insomnia. And basically, there are multiple causes of insomnia, you notice. So it's thought to be a combination disorder, just because even though we call chronic insomnia or insomnia like one disorder, it can have a lot of things that can contribute to it. And the classic symptoms are an inability to fall or stay asleep when desired, and you have a conditioned arousal or awakening to the bedroom environment or sleep-related activities. So what that means is as bedtime nears, you start to get more awake. And then you start to have increased somatized tension at bedtime. What that means is that you start to get more tense, either biobehaviorally, physiologically, emotionally, mentally. You just start to get more tense as bedtime approaches. And these are typical associated symptoms. And you can see there's a whole host of symptoms that are associated with insomnia. And a lot of people that do have insomnia experience one or more of these conditions. Now, the common types of insomnia are this thing called psychophysiological insomnia, which is a disorder, as I mentioned, of this increased tension and learned sleep-preventing association that result in a complaint of insomnia and associated decreased functioning during wakefulness. Now, a typical scenario will be a person that didn't have that much problems with sleep until a certain point in their life when they might have had, say, loss of a job, death of a loved one, a divorce, any stress-inducing situation, and then their sleep became pretty bad. They were unable to sleep well. And if they didn't get that treated or addressed soon, what happens is that can develop into chronic insomnia. And what's interesting is that it's called psychophysiological or biobehavioral in the sense that there might be this behavioral event that somehow affected the chemistry or neuroanatomy to a degree that we don't understand at the present time. And that persisted, even though the original behavioral event might have been improved. So to go back to that example, the person who had loss of a job might have found a job that was even better than the job before. They might have entered into a relationship that was better than the previous relations that led to the divorce. And they might have overcome their grief, even though it might have taken a while, of the loss of a loved one. So the behavioral event that initially triggered the event might have been improved, but still they have the insomnia. That's why it's called this psychophysiological biobehavioral, because they still have this insomnia that might be a direct effect of the behavior on brain function, which at this point we don't understand. So that's a very common scenario. Another common, less common scenario is idiopathic insomnia. And these are the people that will come into our lab saying they haven't had a decent sleep since when they were born. And it's been a lifelong problem. And that is, our assumption is that there definitely is an abnormality of their sleep-wake control, and which we don't have an explanation of at the current time. These are some of the other complicating insomnia diagnoses, things like jet lag syndrome, shift-work sleep disorder, irregular sleep-wake pattern where they don't have a consistent sleep-wake schedule, delayed, which is a very common condition in adolescents where they tend to want to sleep later and get up later, and advanced sleep phase, which can be common as one ages, non-24, which you've probably heard about some in relationship to some newer medications, which primarily affect non-sighted individuals, where they tend to just what's called free run, meaning they just have a schedule that is not aligned to the outside environment. And then there's also sleep disorders associated with mood or anxiety disorders. So what do we do? Well, first thing, as I mentioned, we try to determine fatigue versus sleepiness. I mentioned, although they can be along a continuum, people that are more fatigued and tired tend to fall more in the insomnia realm, where people that tend to have direct sleepiness during the daytime is more things like obstructive sleep apnea. And it's not completely a hard and fast rule, and as I mentioned, there's a continuum. We also tend to look at etiological contributing factors, and we try to validate self-reported data, meaning that we have you fill out the Epworth scale. We also have you fill out some sleep logs or sleep diaries to just look at the data. And this is an example of one of the sleep diaries that we might pass out to you, just to get an estimation of your sleep-wake schedule. Now, we tend not to order an in-lab sleep study for people that we suspect have insomnia. The reason is just as what you might expect for their sleep is what we see. So what we'll see is it takes them a long while to fall asleep, and we will notice that for most of the time that they're in bed, they're not asleep. We'll see increased number of duration and awakenings. We'll see a typical decrease in the non-REM stage 1 or N1 sleep, and a typical decrease in slow wave sleep. We don't need this test to sort of back up what we hear from the patient that does have insomnia. The only reason why we might get an in-lab sleep study is if we feel that there's a complicating diagnosis with the insomnia. Like, do they have also sleep apnea? Do they have periodic limb movements? Other conditions that might be fragmenting their sleep that might make it difficult for them to fall back asleep. General treatment, we tend to use behavioral treatments first. We will also try some of these techniques, which I'll go into briefly. And occasional mild hypnotic may be used on an infrequent basis, and I'll also cover that. Psychologic or psychiatric counseling may be useful, particularly in people that have complicating diagnoses with depression and anxiety disorders. So these are some of the common over-the-counter agents that I use. One of the problems that we have with things like diphenhydramine or Benadryl is you notice the half-life can be very long. And same thing with some of these other over-the-counter agents. Also, antihistamines, as I mentioned, it's problematic because right now they're one of the more commonly used over-the-counter treatments for insomnia, but there's no systematic evidence for their efficacy. There's significant concern about the risk, there's tolerance, and there's also a lot of adverse effects. And what's shown here for diphenhydramine, the active ingredient, things like Benadryl, you can see for elderly hospitalized patients, there's significant effects in their cognitive state compared to people that aren't exposed to the diphenhydramine. Now, melatonin, I always get this question that it can be very beneficial for people that have shift work sleep disorder, also jet lag and other circadian rhythm sleep disorders. It can have also a positive effect in some individuals with insomnia because it can phase advance the major sleep period, meaning that it may make the sleep-wake cycle shift earlier in the night. And that might be beneficial, particularly for people that have insomnia. Valerian is also another thing. The only thing is that there's probably less evidence that it shows benefit beyond that provided by placebo. And most commonly, it's used in a tea preparation. You can see that in terms of prescription medication, this is a slightly outdated slide in the sense that it's from 2004. Was when the study was published, but it is still pretty accurate in terms of trazodone is still really heavily prescribed to treat insomnia, followed by things like Ambien and other medications. Antidepressants, as I showed, trazodone is used, and in the short term, it's sedating and can improve some sleep parameters. Doxaprin can also have some beneficial effects, but data on other antidepressants currently is lacking. Benzodiazepines, benzodiazepines such as Ativan and Valium can also be effective in short-term insomnia management. However, right now the adverse events kind of outweigh the benefits, and as a consequence, we tend to shift more towards other newer agents. And one of the problems with the benzodiazepines, as you notice, is a lot of them still have fairly long half-lives, either the initial or parent medication or its metabolite. That's why we tend to, and this just continues on more benzodiazepines. That's why we tend to, if we have to prescribe a short-term agent, we'll tend to go with these benzodiazepine receptor agonists. And I apologize that this is in its generic form, but isoprolol goes by the name Lunesta, Zaloplan is Sonata, Zolpidem is Ambien. And you can see why these medications, although not perfect, have advantages over the benzodiazepines as well as the over-the-counter in the sense that the half-life is shorter, much shorter compared to the other medications. And in some cases, the onset of action is higher. And this is some of also the newer agents, things like Romaltion, which is Rosiarum, and Suvorexant, which is, I'm just blanking on the name of it. It's the one that's really pretty heavily advertised now. But you can see that these are some of the newer agents, and they do have their applicability for certain cases of insomnia. But these are the adverse events, and a lot of these are common to both the benzodiazepine receptor agonists as well as some of the newer agents. And one of the things that troubles us is the anterograde amnesia, so as well as the parasomnia. So as you know, they can, some of them have been linked up with things like sleepwalking, as well as there's some emerging evidence now to indicate this cognitive psychomotor impairment, particularly, could it possibly link to development of Alzheimer's? And I think that's still an open question for the time being. So what is the most effective treatment for chronic insomnia? It's actually cognitive behavioral treatment of insomnia. And this consists, this is a sort of a catch-all term, but it consists of these individual treatments which may be combined or may be individually given dependent on the patient's main insomnia problem. And you can see the goals that are listed here for these individual treatments. Now, some of the things that are associated with are relaxation therapy. You can see that the sleep efficiency can improve up to about 72% for non-medication patients with insomnia. And this can consist of things like progressive muscle relaxation, where they'll either tell you or you'll listen to audio tapes of tightening and relaxing your fingers, then your arms, then your whole body in a progressive fashion. And you can actually decrease wake time after sleep by 20 to 30 minutes. Meditation, self-hypnosis, biofeedback can also improve the sleep efficiency globally. Sleep restriction is a more complicated technique that's practiced by the cognitive behavioral sleep specialists. But basically what it can do is it can reduce the wake after sleep onset by 54% and improve the sleep efficiency by 24%. This is the standard way of doing it. A more abbreviated way is what you can tell the patient is to set their standard awakening time, and then their optimal sleep length, you tell them to decrease that by 15 to 30 minutes each week. So let's say they sleep at from 10 p.m. to 6 a.m. You tell them every morning to get up at 6 a.m., but then you tell them to start going to sleep at like 10:15, or in some cases 10:30. And then you tell them still to get up at 6. The next week, you tell them to decrease their sleep amount by that same amount, either 15 or 30 minutes. But you choose one or the other. This says 15 minutes, but there's other protocols that go by 30 minutes. Eventually, you reach a point where they become very sleepy during the daytime. And then that's when you back off by the 15 to 30 minutes of the bedtime. But you can, it really translates to improvement into the wake after sleep onset and improvement in their sleep efficiency. These temporal and stimulus control techniques, you can see what that consists of over here. The 20-minute rule is what we tell them is that if they can't fall asleep or can't fall back asleep within 20 minutes, they should get up, go to another room, and do something that makes them drowsy. When they feel drowsy, then go back to the bedroom and then try to go to bed and try to sleep. But they shouldn't look at a clock when they should estimate this 20 minutes, because looking at a clock constantly is a sleep alerting activity. And you can expect improvement over 50% after 1 year using some of these techniques. Cognitive therapy is, this is also prescribed by the behavioral sleep medicine specialist, but basically you're trying to modify thoughts that are interfering with sleep. And these can be grouped into things like worry, effort, and control. And then you challenge their avoidance behavior as well. Phototherapy is also very important. You tell them to avoid bright light in the evening, particularly about 2 hours before bedtime, because that can phase delay the person or delay their onset of sleep. And in the morning, it's very important within 5 minutes of getting up to expose themselves to about 30 minutes of bright light, at least 2,000 lux. And most light boxes are at least 10,000 lux. And if you go outside in the morning, if it's bright when you want to get up, you'll get thousands and thousands of lux. And the reason why this is important is it activates the nucleus, the suprachiasmatic nucleus that I talked about earlier, and that helps us synchronize the internal clock. So in conclusion, there's, oh boy, really went over, but in DO's, there's maintain regular bedtimes and awakening times, optimize your sleep amount, try to get bright light in the morning, create a comfortable, quiet, dark, and temperature-controlled better environment, and establish a regular pattern of relaxing behavior within an hour before bedtime. This can include things like just meditation, deep breathing, anything that relaxes you. And try to get exercise on a regular basis, but try to avoid it within 2 hours of bedtime, because that can be activating. Avoid taking a nap. Now, there's always caveats, and you should take a nap if you're about to get behind a wheel of a car, obviously, and you're sleepy. The other caveat is if every day you take a nap at the same time for about the same amount of time, then that's fine because your body's used to it. And if you really have to take a nap, like say if you're really drowsy and about to get behind a wheel, the optimal timing of the nap is actually about 20 minutes. Because if you take a nap longer than that, you can get this thing called sleep inertia, which is you start getting into very deep sleep, like N3 sleep, and that's why you'll end up feeling more groggy than you were before you took the nap. So the optimal length is 20 minutes. Now, if you're very sleep deprived, you should even adjust a nap to make it even shorter. I know it sounds counterintuitive, but the reason is that if you're very sleep deprived, then you'll get a non-REM rebound. So you'll get into the very deep sleep really quickly. So you want to avoid that. You just want to get the light sleep, which is just enough to keep you going for the next few hours. But it's enough to avoid making you feel groggy because of the entrance of the deep sleep. You should avoid eating or drinking heavily before bedtime. You should avoid lying awake for long periods of time. You should set that 20 minutes. You should not allow disturbances. You should avoid reading or watching television in bed unless it definitely makes you drowsy. And you should try to avoid alcohol, caffeine, or nicotine. So that's it. This is our lab, clinic and lab over in Redwood City. If you have any questions, you can reach us through our main clinic number. And we also are in Stanford My Health as well. So thank you. I realize it went quite a bit over time. Thanks. And I'd be happy to entertain a few questions. And if you also have questions that exceed time, you can always come back by a little after up here.
So my grandmother took Ambien for 30 years, and now she's 95, and she told me that she lose a little bit of memory after taking Ambien for 30 years, and I thought to myself, man, I'm not so sure if I can last that long, but how true is it that Ambien can reduce your cognitive potential?
Yeah, so Ambien has definitely been associated with decreases in cognition, particularly on the day after taking it. If it's a more chronic effect, it's hard to tell whether or not it's really attributed to the Ambien. As I mentioned, there have been just a few studies that have kind of tried to have shown that there might be an association with some hypnotic medications with possibility of dementia. But that's still a moving target and needs more work. The safest thing probably to do would be to avoid those medications moving forward, because realistically, the only thing that tends to really work for chronic insomnia is cognitive behavioral therapy. That's been shown multiply in the literature that for people with chronic insomnia, that's the only thing that tends to work over time. So these medications are mainly designed for short-term insomnia to sort of break the cycle of poor sleep, because if you don't break the cycle, there's a good chance of it developing into chronic insomnia.
Do singers get less sleep apnea because they're exercising their upper palate, their diaphragm, and their vocal cords?
Yes, that's kind of interesting. It was first actually reported by one of my colleagues who's in Brazil. He did this study where he looked at people that had obstructive sleep apnea who played the didgeridoo, which is an Australian wind instrument. And the idea behind that is to provide or when you're blowing that instrument, you actually have to maintain a continuous tone. So you do this kind of like rebreathing. And he was actually shown in a limited sample size to actually show that there is a difference in limited sample patients for people that had apnea compared to those that didn't use the instrument. Since then, there have been a handful of studies also showing that people that play wind instruments, there might be an effect there as well. So it's not just specific to the didgeridoo. It might be that using these wind instruments actually help to maintain the upper airway tone. And now there's actually an expanding group within our field looking at myofunctional therapy, which has originally been used for stroke, for people with stroke to sort of strengthen the upper airway muscles. And that right now, there's been definitely papers looking at that, and even a paper from our lab that showed that in an evidence-based review that there was an effect on people that did have obstructive sleep apnea. It's still too early to tell because it's still somewhat limited sample size, but it does show to be an interesting effect on people that have sleep apnea.
You mentioned that when you get your anaminoid and tonsils when you're just a child, it's more effective than as an adult. Is that just because, well, like why? I guess I'm curious.
Yeah, so in children, so her question was, why is there a difference, for children that have adenotonsillectomy, and it can be curative, whereas in adults, it might not be. The reason is, in children, it's fairly straightforward. You will take out the tonsils and adenoids, and I also forgot to mention that one of the things we also will do in combination with that oftentimes is a distraction. So we'll actually expand the maxilla and mandible. So we'll actually expand the upper and lower jaw size. That will also expand the upper airway. So that in conjunction will help children. What we found in adults is when I showed that slide, they can have collapse in not only the nasopharynx, which is the nasal area, but they can also have it in the oropharyngeal, hypopharyngeal area. And that comes after years of just decreased tone in that space. So just by taking the tonsils and adenoids, in most instances, unless the tonsils and adenoids are huge in adults, a lot of times it is not curative. We frequently have to do, more. The surgeons have to do more invasive measures of correcting the apnea.
Can you say a few words about terminal insomnia?
Say that again. Terminal insomnia.
Terminal.
Yeah. So I'm assuming that you're referring to fatal familial insomnia. So fatal, and is that?
I'm sorry. Late, early awakening, premature awakening.
Oh, okay. So So what he's referring to is awakening earlier than the person desires to awaken. So that can definitely be a symptom of maintenance insomnia, where the person just wakes up earlier. It can also be a sign that the person might, or a symptom that the person might have depression, because early morning awakenings is one of the classic symptoms of a person that does have depression. So that should be examined. But if the person it doesn't necessarily mean that the person is depressed or has depression, but is one of the things to look at. But if the person consistently wakens up at that time in the morning, let's say they wake up at 3 o'clock and their normal awakening time is like 5 o'clock. One of the things that we'd want to do after trying some of the cognitive behavioral therapy, if that doesn't improve, is to have them have a sleep study. The reason is that when the person has like that terminal awakening, I showed the slide that shows that the REM sleep periods tend to get longer and more intense as the night wears on. One of the things we really become suspicious of is if the person has these awakenings towards the morning, does the person have apnea? Because if the person has apnea, it will tend to occur, most severely in the REM period, and that tends to occur, the longer and more intense REM period tends to occur right before the person wakes up. So that's what we would be concerned for. But those are, I think, in terms of likelihood, would be, people that might have maintenance insomnia, depression, and or obstructive sleep apnea would be some of the things we would look for.
How long does it take to get into the Stanford Sleep Clinic for an evaluation?
Yeah, so this is something that we've been really trying to fix, because right now our wait times for new patients is about 3 to 4 months. For the established patients, it can be that length or even longer. For our sleep studies, we actually worked on a project that actually took about 18 months, where we reduced our wait time for our in-laboratory sleep study from a mean of about 86 days down to about 60 days. So we have improved that, and we have also increased our use of the home sleep test to help with the diagnosis of obstructive sleep apnea. Now, with that preface, if we feel that the person urgently needs to get in, we will get get the person in sooner, both for the sleep study as well as for the visit, because we do have mechanisms for helping with that. In addition, we are trying to recruit and hire more sleep specialists in our lab, because we do realize that it's a problem, and right now we are a little bit constrained by space, but also by people that are willing to actually relocate here to be practicing with us. But we are having active search out for new faculty physicians, and hopefully that will decrease the visit wait length.
What is an optimal dose of melatonin?
Yeah, so her question is, what is an optimal dose of melatonin? It kind of varies, because there's various preparations, but I think, if I was to pick the dose, I think it's about 3. I think the active preparation is about 3 milligrams. I think is commonly one of the more common starting doses. I think it's 3.
And with taking melatonin, how does the time take it before you want to go to sleep? How does that?
Yeah, so the timing of melatonin is really critical, because as I showed that graph in the beginning, what happens is that the most effective time is actually when the core body temperature is at its lowest point. The problem is that that body temperature drop will tend to occur anywhere from like 1 to 3 a.m. in some people, and sometimes it will also have its nadir in 1 to 3 p.m. as well. The problem is, if you give it at that point, that really doesn't sit well with most people that want to sleep at, say, 10 p.m. And there are studies to indicate that if you give it at the wrong time point, when the core body temperature starts rising, that's when the person, it might actually heighten insomnia or the ability to fall asleep. That's why, that's why one of the things that we recommend that we don't discourage patients from trying it, because it can be very effective in certain individuals. But we preface it by saying that, it might not be that effective for you just because of the time course.
So we only have time for a couple more questions. I see a hand back here in the back.
In the beginning, when you started, you said you were going to talk about restless leg syndrome, and you never did.
Oh,
But
okay, sorry.
no, but I just have a question. I happen to have both restless leg syndrome and sleep apnea, and you see that. Is there a correlation? I mean, do a lot of people get both of those things, or?
Yeah, so just really quickly, I'll just say that, restless leg syndrome, for people that aren't familiar with it, it occurs about 10% of people in the world have this condition. It's in the top 3 of conditions for sleep problems, along with sleep apnea and insomnia. It's a condition that's characterized by an urge to move your legs that's worse at rest, worse at bedtime, but temporarily relieved by moving the legs. The main treatment of it is by medications, and specifically your question was, is there overlap between restless leg syndrome and obstructive sleep apnea? No, there isn't. But interestingly, people that, if a person has restless leg syndrome, about 80% of people with restless legs also have periodic limb movements during sleep, which means that their legs twitch repeatedly during sleep. And that's also well treated by the same medications that I use to treat restless legs. The reason why I bring that up is sometimes people with obstructive sleep apnea will have leg kicking during their sleep, which might be independent of this periodic limb movements. But the reason why we notice that is that at the end of a period of apnea, they might kick their legs just in the struggle to get a breath in. And sometimes that's misdiagnosed as periodic limb movements during sleep. So that's the only overlap. And one thing I do want to say is, if you're diagnosed with restless leg syndrome, I just want to make really clear that there's no evidence to indicate that the person will develop Parkinson's disease, because the same medications that are used to treat restless legs, the most common medications, provide extra dopamine to the system. And so sometimes people conclude, oh, well, they're giving me a Parkinson's drug, does that mean I'll get it? But the prevalence shows that a person with restless legs syndrome has no higher likelihood of developing Parkinson's than the general population.
Thank you so much. I really enjoyed your presentation. And my name is Dr. Avinash. I came all the way from UCSF, and it was worthwhile to come here. The question I have seen is, most of the time in patients in bipolar disorder, their mood rhythm has changed, and so that their sleep pattern has also changed. So what are some treatments for the patients who is suffering from bipolar disorder?
Yeah, so the overlap with bipolar disorder is oftentimes they will have insomnia. And so if the patient is on already medications to treat the bipolar disorder, we have to be very careful about if we need to prescribe a short-term medication. But in general, what happens is that our first step is actually to get them into cognitive behavioral therapy. Now, if they are on an antidepressant, one of the things that we're always cognizant of is that there are some sedating antidepressants and alerting antidepressants. So we want to make sure that that is in alignment. And we'll never just go ahead and obviously change their antidepressant because for one thing that might further worsen their sleep. And on top of that, it will make psychiatrists such as Dr. Alan Louie very upset at us. So we won't change their antidepressants. We will, first of all, just try to get them in to see our cognitive behavioral specialists to work on their insomnia, and then perhaps provide some guidance that they can pass back to their psychiatrist or primary care physician who's prescribing the medication, what we must possibly might recommend in terms of the selection of the medication.
Thank you so much.